Well, good day. Welcome to Mind Your Health. Today, we're excited to have Dr. Mark Liwanag, who's an electrophysiologist with Novant Health. And Dr. Debbie and I are going to learn all about today the heart and how you can help us.
That being said, people should, and that's kind of my mission. My job is to keep people doing exactly what they want to do, keep them, out
Active
there. Yeah,
lifestyle.
absolutely. No, I mean, it's great to be part of a community where we have a lot of people who are very active, playing pickleball, playing golf, getting out there. And that's kind of the idea from a heart rhythm standpoint, is to, if they're having arrhythmias or issues, to keep them going and keep them doing what they love.
Mind your health.
Got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
I'm excited to have you. I've had the privilege of talking to Dr. Mark before, and it's been really, really fun because I think when I think cardiology, I don't think electrophysiology, and I don't really even know what that means. So let's kind of introduce you again and say thank you for joining us,
Yes.
and talk to us about the heart, about electrophysiology, and wow, cardiology is really in the 21st century.
Oh, for sure. So electrophysiology is electrophysiology. We're dealing with it's the complex management of arrhythmias. There's a couple different ways to manage arrhythmias. Arrhythmias, of course, are abnormal heart rhythms. There's medical management, then there's also procedures.
Okay,
So in
time
terms of
out. A medical, all right, don't you love this?
Medicine,
Okay,
or they
medicine.
go in and fix something anatomically.
Isn't he so
that's
helpful?
that's absolutely, hit it on the head.
Okay, and so
Lucky
cardiac,
guess.
Yeah.
no, and so cardiac arrhythmias are just when things are not pumping the way they should be pumping.
Correct. So we're talking about the electrical activation of the heart.
Okay.
So usually the way that the heart's supposed to work is you have your natural pacemaker in the high right upper chamber of the heart, called the sinoatrial node. It fires about 60 to 100 beats a minute, and then it sends electricity to the bottom chambers by going through the atrioventricular node. The AV node brings it down to the bottom chambers, and then so it's nice and coordinated.
Can you tell he does this for a living? I'm like, look, talk to me about the chamber again. You're like, oh my God, Debbie,
Sure.
stop it. But keep going.
Oh no, that's basically, so that's the natural. That's how the heart's supposed to be electrically activated. However, things can go wrong, and that's where that's where I come in.
Exactly. Do you think people realize that the heart, I think of the heart as a muscle. I didn't realize there was so much electrical connection to that.
Mhm. Yeah, the heart is it's a complex and fascinating organ for sure. It's a muscle, but the heart's like a house. There's there's plumbing, there's electricity, there's windows, there's doors. And yeah, there's a cardiologist for all these things, and there's cardiologists who take pictures of these things, and that's what they do too.
No,
Yeah. Yeah, and I guess
Right?
there's also a surgeon who can change the house over if you need to
Oh, like an
change that.
architect. I
Yeah,
love
something like
that.
that.
Exactly.
But yeah, so people, when they have heart attacks or having a blocked artery, there's a plumber who takes care of that. They deal with interventional cardiology, will deal with the arteries and fixing, putting
Okay.
stents into the vessels to fix a heart attack.
I love that. That's the
So
plumber.
that's kind of the plumber. I'm the
Okay.
electrician. When the electricity goes off, yeah, that's I get the phone call.
So what makes the electricity go off? I love talking about it like this because it actually puts it in words where I can
Yeah.
semi understand. Doc. Doc.
You're good. You're good. You're among friends.
Okay.
All right, now it gets a little bit hairy now that you just said that. Okay,
Okay.
so wow, how does the electricity go wrong? Okay. Over time, sometimes people develop scarring. They develop scars or fibrosis that can occur over time, whether that's from just living or things like a heart attack, and then that could be a reason to have an arrhythmia of some sort. And
Okay.
also, yeah, again, sometimes the electricity, like I was describing, the natural way that electricity gets from the upper chamber of the heart down to the bottom chamber of the heart.
Okay.
If there's any slowing along the way, the heart's, like the house. Over time, when when the heart house gets to be 50, 60, 70, 80, 90, 100
Right.
years old. Sometimes the electrical wiring, also ages along with that. And
Exactly.
sometimes things go a little bit slower. But yeah, there's a couple different ways to get arrhythmias or have
Are
resistance
all
issues.
arrhythmias bad arrhythmias?
Not necessarily.
Okay.
Not necessarily. Uh, I mean, it's a whole spectrum. There's benign arrhythmias spanning from upper chamber extra beats that, we all kind of get, like premature atrial complexes, early extra beats coming from the upper chambers of the heart. Those are pretty benign. They may not feel good, but they're pretty benign.
Not so bad.
There's ones from the bottom chambers of the heart, which can be not so good for you, especially if you have a lot of them, premature ventricular complexes, bottom chamber extra beats. If you have a bunch of those in a row, that could be potentially lethal. But my focus tends to be more on upper chamber arrhythmias, so like atrial fibrillation, atrial flutter, supraventricular tachycardias. These things, they make people not feel so well, but it's not exactly the
You're
worst.
gonna love my question. I know,
I love
David.
all of your
I'm
questions.
sure you. No, you're gonna like the. Ugh. Okay, in the world and the era of
Oh, okay.
Aura rings and of you were like, what is
Yeah,
and of Apple Watches,
Mhm.
I think we are more and more familiar with words like tachycardia or atrial fibrillation or all of those kinds of things. In general, can you talk us through how the heart works in a way that we might understand, and then what some of those arrhythmias would be doing that would be a problem for us? This is gonna test you guys both to see how do you say that in like.
Well, so hold on. The question is,
So first is, what is the function of the heart, and kind of generally how does it work?
how does the heart work?
Mhm.
Okay.
What's it
so-
You're
supposed
gonna
to-
start at the basics.
Yeah, but,
Okay.
well, yeah. What's it supposed to be doing? Because I'm already assuming that we all know what we think it does. Do we know what it does?
Yeah,
I
we
don't know.
pumps your blood.
Yeah, you got it. So yeah,
Okay.
It's a pump.
the
It's a
heart the
pump.
heart's a pump.
Okay.
The heart's a pump. The idea is that it takes oxygenated blood and it pumps it through and circulates it throughout the body.
Got it.
Yep.
Okay, that we started there,
Mhm.
and and then it's got all the pieces of the house, the electricity, the plumbing, and things like that.
Mhm.
Sometimes when those go wrong, we have flutters or little hiccups or like a clog in the drain or whatever it is.
Sure. So yeah, if there's issues with the pump, then there's issues with the pump, then the blood's not circulating very well. And then we run into things like a term like heart failure. Heart failure is always a scary term, that failure where it's
Yeah.
pretty bad. But there's basically two types of heart failure. There's one where the pump is it's not working so good, it's a weakened pump. And
Okay.
then there's one where the pump works fine, but maybe it doesn't relax very well. So we're talking about heart failure with reduced ejection fraction, where the squeeze of the heart, the strength of the heart is down, versus heart failure with preserved ejection fraction, where it just basically doesn't relax.
It's
very
just
well.
not working.
And so, yeah, so if the pump's not working well enough, then people can get symptomatic with this, where, they start to retain fluids or stuff like that. In my line, if you have a reduced ejection fraction, if the heart muscle is weaker, you're actually prone to, patients are at risk of having bad bottom chamber heart rhythms, like ventricular tachycardia, ventricular fibrillation, where, they can, the heart pump doesn't work very well.
Right.
They pass out and don't wake up.
Oh, we don't like that at
Yeah,
all.
that's right.
How do most people find you?
Thank you.
So
sure.
do I go to, my regular cardiologist and he's listening and or how about what are the symptoms of arrhythmia that's going to show up? And is my cardiologist going to send me to you? You don't see people like just walking in off the street, rarely, right?
Not
You're,
quite.
you're always referred either like through the emergency room or the cardiologist.
So there are, okay, so why would somebody see an electrophysiologist?
Yeah.
Arrhythmias, sometimes palpitations, and palpitations, feeling extra flip-flopping heartbeats. That can sometimes get referred to me, and then we put a monitor and we see what we gotta do. That is like a telemetry thing to look at, look for abnormal heart rhythms. So sometimes I get or other reasons for arrhythmic issues. So palpitations is one symptom of an arrhythmia. Other people, like passing out, fainting.
Okay.
Other ways that people get to me, people get to me through different ways,
Like primary.
their family doctor,
Yeah.
primary care doctor, through the emergency department, or by referred from like another cardiologist. So like I was saying, symptoms of arrhythmia, abnormal EKG, whether the EKG shows an arrhythmia that someone may actually not even be feeling. Sometimes that happens too. And then people showing up through the emergency department, and then getting referred my way for other types of arrhythmias, or things like I already mentioned, passing out, palpitations, new diagnosis of atrial fibrillation or what.
So what do you actually do with that electrical wiring? how do you treat? What is an electrophysiologist actually physically doing to the
Sure.
patient?
Okay. So there's different types of arrhythmias, of course, and they're all going to be treated differently.
Okay.
Okay. So, and then in the management of arrhythmias, I guess there's a couple ways to do it. I mean, I mentioned, medical management and then also
Medicine.
procedural management, but of course there's going to be things, like just lifestyle changes, whether that's going to be, drinking less coffee, getting better sleep. Oh, somebody has sleep apnea, which is really, really bad. I think we vastly underappreciate how bad sleep apnea is for people. Sleep apnea, there's a couple different types of sleep apneas, obstructive versus central. Obstructive is where, we're lying down flat and in the soft tissue in the neck
Okay.
kind of compresses the airway. And then we have low oxygen in the blood. And if we're doing that as we're sleeping 6, 7, 8 hours a night, low oxygen in the blood is pretty bad for you. It can lead to high blood pressure, fatigue, not feeling well, and then arrhythmias. Oh,
Okay.
and even, yeah, weight gain, just not feeling well.
Right.
So there's that. And then there's central sleep apnea where neurologically people stop breathing and stuff like that. But yeah.
Neither sound good.
I mean, I'm sure they're manageable.
Right.
But yeah, there's lifestyle changes, eating, drinking well, just the regular healthy living, and then there's medical management in ways that we manage arrhythmias, and these are talking about antiarrhythmics.
Is that what you would? Okay.
Correct.
So antiarrhythmic medications, a lot of people, most other specialties, they kind of get kind of weird about it because they don't manage them that much,
Mhm.
and it definitely takes a little bit of extra training, a little bit extra thought, to use antiarrhythmic medications. They're not very common. In terms of your world, there's medications like dofetilide, brand name Ticacin, sotalol, things that mess with the electrical resetting of the heart, and common antibiotics and other things can mess with these with the EKG findings, and that could be put people at risk for having sudden cardiac death. So
Mhm.
we have to be very specific and very tailored and very careful about how we use these medications. And then some of the other medications, they you can just take them and they work just fine.
So as an alternative to the medication, we look at some of the things that you do, ablations. Talk to us a little bit about specifically what those things look like and are.
Sure. So, some people can't tolerate or do not tolerate antiarrhythmic medications, or simply they just want to be on less medications, and that's totally fine. I definitely understand it. Sometimes, for sure, less can be more. So if someone is not tolerating, or this maybe the best way to do it is going to be with a procedure. A lot of times, what we're talking about in terms of arrhythmias is going to be something like an ablation. Ablation itself, in terms of heart tissue, cardiac stuff, we're talking about damaging heart tissue purposely to cause scar. Scar does not carry electricity. We create patterns of scar to break up circuits that lead to arrhythmias.
I mean, that sounds pretty intimidating and scary. What does it actually look like in practice? I mean, what would it look like for a patient? What would they experience?
Sure. Most patients typically what they do is they come to the hospital. We get them set up in our lab that looks like the inside of a spaceship,
Okay.
and then they go to sleep and then they wake up. That's
Is
usually
it
how it
really?
goes.
Is it?
That's usually how it goes.
And they're better.
Yeah, that's
I
usually how
love
it goes.
this.
Yeah,
Okay.
and then they wake up they wake up on the table. We move into the postoperative area. They're surrounded by our amazing team of our amazing cath lab, EP lab staff, and then they're happy, and then they go home. That's usually how it goes. But I mean,
Well, so I just want to go a little bit deeper. Is the heart beating while you're doing this?
yes,
Okay.
yep, okay.
I
So
mean,
See,
what are
that's
you
such a
watching?
good
You're
point.
watching it on you're threading something on, watching it on the screen.
yeah, so the fun thing about my job is that
I love it.
there's things where we're looking and we're actively working on something, but the arrhythmia management and all this ablation stuff, maybe my colleagues will be upset that I'm saying this. It almost turns into a little bit of a video game.
Oh, does it really?
They
Instant
they may-
gratification.
Well, I don't know if it's instant gratification, but it looks, because we're, like you were saying, the heart is beating the whole time. So if you can imagine that we have these catheters, these instruments, these plastic catheters, these plastic tubes with little metal bits on them. They're in the heart while the heart is beating, and we're tracking these catheters in different ways. They're both connected to the computer. There's different ways to build like a computer map that we do. There's a couple different ways to do it, but yeah, these are all hooked up with computers, and it generates a computer image. It really looks like a video game. And then I'm also looking on echocardiogram quite a bit for direct visualization or not direct, but we're getting some imaging of the catheters as we go
Okay.
along as well. There's a couple different ways to do it. We can use X-ray as well, but I try not to use X-ray.
Okay.
But
It's amazing.
Yeah.
And then
There
it's like
should be
zap.
there should be videos of some of this stuff kind of float. I think there's videos kind of floating around somewhere.
Yeah, that'll be fun.
it's on
if
the
we,
pit.
yeah, it's on the pit.
Yeah, I haven't seen that. I've seen
Oh,
maybe like
have
an
to.
episode of it. It'd be interesting.
It's so good.
EP
It's so,
is not made for TV. I'll tell you that.
No.
If you watch our cases, they're not made for TV.
No.
It's pretty boring in
is
there.
it really?
I mean, I think it's
So
great.
then you go like zap.
So there's different ways to do ablation. Ablation, what I was
And
saying,
I
damage in
I
heart
have such
tissue.
a Call of Duty.
Yeah. There's a couple of different ways to do it, whether we're heating the heart tissue to cause that scar, and then there's a new way of doing ablation called pulse field ablation. It's a new kid on the block. Every manufacturer is making their own version of it,
Okay.
where it's electrical impulses that signals to the cardiac cells specifically to poke, nanopores, very, very small holes in the cell membrane. The cell guts spill out, they they become
know.
electrically inert. It's
It's
a
magic.
fantastic time to. It's basically magic. Yeah.
That's
Oh.
amazing.
Yeah.
So were you a cardiologist first,
Great question.
and then you went
Mhm.
like were you I hate to say regular, but a
General kind of.
general cardiologist,
Internal
and then you
medicine
said,
first?
"This is what I want to do. I want to do this and specialize in the electrophysiology part."
Yeah, great question. So, okay, to become an electrophysiologist, it takes a while, which is probably why there's not enough electrophysiologists out there. So it's 4 years of medical school, followed by 3 years internal medicine training, and then 3 years cardiology. And then after that, it's 2 years of electrophysiology training. So after graduating medical school, it's about 8 years. It takes a while to become an electrophysiologist.
A couple of the other things that you do, pacemaker
Mhm.
and Watchman. Can you talk us through? Because I think those are all things we hear about in the news, and it would be nice to kind of understand.
Sure. Okay, so there's pacemakers and cardiac implantable electronic devices. So that would be pacemakers, defibrillators, things like that.
Oh, okay.
Okay, so there's those devices. They each have their own different indications. Pacemakers are for people who, the electricity is kind of slow for whatever reason. Their heart's not fast enough for what their body needs. Whether that's because of the natural pacemaker that I described in the high right upper chamber of the heart called the sinoatrial node. Whether that doesn't speed up, like if I ran up the stairs from whatever a couple floors down,
Right.
my heart's probably going to go, I don't know, 115, 120 beats a minute.
Sure.
There's other people who will try to do that and their heart rate does not go up for whatever reason, and so maybe they don't feel so good. Maybe they need a pacemaker. So
Okay.
that's one thing. Maybe the natural pacemaker doesn't work.
Genetics too.
Oh, it's just sometimes just age and living.
Yeah.
Could be genetics.
I love it.
Um,
Age and living. It's a
yeah.
good thing. It just happens.
It happens.
Just roll with it.
And then
Love it. It
so-
happens.
And then sometimes the electricity just doesn't get to the bottom chambers of the heart. Then we got to put a pacemaker for that. And then there's defibrillators, devices that will, for people who have bad bottom chamber heart rhythms,
Okay.
it'll watch and wait for it and then pace them out of it if it happens, or it'll shock their heart and they continue living. Okay.
Okay.
So those are things pacemaker, defibrillator.
I love listening to you describe it. I mean, the way you're describing it is just just boom, 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 boom.
Well, isn't it true that some people that have the implantable pacemakers don't even feel when it's putting them back into rhythm? It's so subtle.
So pacemakers, hopefully no one really feels it. There's
Yeah.
ways that
Okay.
they can feel it. Pacemakers, yeah. Defibrillators are kind of interesting because defibrillators, that what the idea is to be able to save somebody's life if they're having a bad bottom chamber heart rhythm, ventricular tachycardia, ventricular fibrillation, where they would otherwise pass out and not wake up. So that's an interesting one. Sometimes people get shocked by their devices and they definitely feel that, oh my gosh, a donkey kicked me in the chest. Other people, if they've had an appropriate firing of their device, they just wake up on the ground at the grocery store, everyone's
Yeah.
staring at them, and that's all that they knew.
Oh,
You know,
interesting.
they're like, hey, what happened here?
Yeah.
And they just continue living. Yeah.
Watchman is a new thing that I keep hearing about. What is that?
So then there's the Watchman device. The Watchman device, it is it's under this it's a procedure, left atrial appendage closure. Okay.
Whoop, say it again.
Left atrial
atrial
appendage closure.
appendage closer.
Yep.
A lot of good words.
Yep. So, okay, the Watchman is used in atrial fibrillation. Atrial fibrillation, abnormal upper chamber arrhythmia, where people have risk for stroke.
Okay.
So the left atrial appendage is a pocket in the left upper chamber of the heart, where 80 to 90% of blood clots can form in atrial fibrillation. That can, if they come out of that area, then it can go to the brain. Someone has a stroke.
Okay.
So the idea of the Watchman is in people in the correct patients, we place this device. It looks like a squishy metal frame with some fabric on top of it. We put this into the left atrial appendage, and then over time, the left atrial appendage closes. The idea is to be able to transition somebody away from their blood thinner, whether it's like Eliquis, Xarelto, Pradaxa,
Yeah.
something like that, or warfarin even, if people are taking warfarin. Transition away from the blood thinner to aspirin and Plavix, which is what people get after like having a stent placed, and then transition to baby aspirin only. Yeah.
Does everybody have that appendage, male, female, regardless of age? And as you get older, do more clots form in there?
Great question.
I guess it's supposed to be on this side.
Great question. It's usually
Okay.
just about everyone has it. Has these just about, I would say 99% of the people will have left atrial appendage. And then as long as, okay, somebody with atrial fibrillation who has significant risk factors for having a stroke, being over the age of 65 or 75, high blood pressure, diabetes, heart disease, heart failure, having had a stroke before.
Smoking.
If you have
Oh,
specifically the risk factors are the kind of the ones I listed. Female gender is actually one of them as well.
female?
Yeah, there's studies that demonstrate females are more likely to have a. It's all figured into this risk calculator.
Okay.
But if you have enough of these risk factors, then somebody's at risk for having a stroke. And that's when we put people on blood thinners,
Got it.
and it greatly reduces their risk of stroke. Not being on a blood thinner, specifically in the absence of having like a Watchman or some sort of other closure, yeah, there's a risk as people go on. There's an annualized risk that occurs. So it's not that they're going to develop more. It's just that, I mean, anybody who has these risk factors, 2 or 3 of these risk factors, depending on who they are, yeah, they should probably be on a blood thinner.
Once you have one of these implantable devices, then do you follow them? There's a relationship between you and your patient. You kind of follow them for how long, or what is the lifespan of a ZAP or a Watchman or pacemaker?
Okay, so in terms of the devices, the cardiac implantable electronic devices, pacemakers, defibrillators, between me and the cardiologist, we'll be following these devices. Typically, these devices will generate a report looking, just kind of describing arrhythmias or
Got
how
it.
these trends in the leads are going and stuff like that. It generates a report at least quarterly.
Okay.
So somebody is going to be following that. The lifetime of these devices is also about, I don't know, anywhere between 8 to 13 years before we got to change the battery out.
So what I hear you saying is that you are sort of doing the procedure, and then the patient will go back to their internal medicine doc or their primary cardiologist.
It'll be between me and the cardiologist. We'll be following these devices.
Okay.
Mhm.
I think
Go ahead.
no, go for it.
Can people kind of track their progress on their phone with the new 12 lead EKGs on their iPhone?
Oh, I love that cardiac.
Yeah, I think the cardio mobiles are. I think those are
Yeah.
great. I think they're nifty little devices.
As long
Yeah.
as you don't use them for evil.
Well,
like
it's going to
every
show
s-
up. The arrhythmia is going
Yeah.
to show up there, right? And it's-
If you happen to have it right at that time.
oh,
But yeah, so
I see.
because people can also have like fast heart rates, and then they're like, oh, let me get my cardio mobile out, and then by the time they get it hooked up to their phone or they have it out, then it's dangerous.
Oh, okay.
It
I mean,
it's
I'm
already gone.
obsessed with taking my like
You?
heart rate. I know heart rate and all that stuff, and it's like this is not an indicator of a, arrhythmia.
Yeah, they're gonna say that medical legally. Yeah,
Yeah.
but
Right.
yeah.
But I think it's absolutely fascinating. And I think one of the things you do well, you've got all the big words, and but it's brilliant, right? To
Oh,
listen to
absolutely.
all of
Right.
this.
Right.
And I think you're able to really, with that house analogy, and then just kind of speaking to us about what those things do, help alleviate the fear around some of these cardiac events. And again, cardiac events are happening in younger and younger people these days.
So, yeah, so for the most part, when I'm talking about arrhythmias, the majority of my practice is going to be atrial fibrillation, which is there's definitely a lot more of it.
Yeah.
Atrial fibrillation tends to happen to people who, the longer that people live, the more likely they're going to have it. So
Well, their heart gets tired.
it's just over time. I think we take on just more stresses and stuff like that to the heart
Oh,
over time. So,
okay.
people living past the age of 60, 65, 70 years old, it's just more likely that they're going to take on these arrhythmias over time.
And then typically those arrhythmias, though, are going to be diagnosed or found by your primary care physician, as opposed to symptomatically, or it's luck of
It's kind of all over. It's a good. That'd be actually a good question. I don't know that answer. Who identifies it most often? That's a good question. I don't know.
Well, I have a random question for you too. As a psychologist, I work a lot with young adults, and one of the things the literature is sharing or showing us now is high uh, folks have high levels of THC and are doing a lot of cannabis smoking. They're seeing a lot of arrhythmias in younger men. I don't know if you've seen that, heard it anecdotally, or read any of the literature.
I mean, there's all sorts of different types of arrhythmias that people can experience. I'm not sure about that though.
Okay.
Yeah, yeah, I'm not sure
It's interesting to
for sure.
follow. It really is. It's been fascinating. Um,
Where I was going to go is I was just people don't understand. When you think about your body, all the and obviously your heart is a muscle, but all your other muscles, you really don't really think about electricity.
no, you
And you think
don't.
about I need to stretch, I need to do this and all that. But it's amazing how everything has to be in balance because you need the potassium and sodium to
Hmm.
help to conduct that electric. I mean, it's
Yeah.
all connected. Now I'm going to be 65 in just a couple of weeks.
Mhm.
I just had a primary care visit, but I didn't get an EKG. How often should I get a EKG?
Oh, he's smiling. That's the go get an EKG look.
Yeah, no, I mean,
Fine. Let me borrow your phone. I can do it here, but
Yeah, true.
I don't know if you necessarily need to have routine
okay.
EKGs. I think it's totally fine.
Okay. I mean, yeah, with no symptoms. I mean, is that the probably if I complained about if I was tired or I know I had a family member that his got arrhythmia every time he had too much to drink,
Sure.
Oh,
you know,
really?
and switched from beer to a cocktail, and it was better. But
Yep. No, that definitely happens. Yeah, alcohol definitely can influence having arrhythmias. It seems to me at least where it's almost like when you're withdrawing or hungover or something from
Yeah.
alcohol tends to happen. But yeah, I mean, consistent drinking can also mess with your electrolytes, like you were saying. You're off balance, messes with your potassium, and then yeah, you could be tipped over into having arrhythmia.
Well,
mm,
let's talk about that in terms of other lifestyle things. What about lack of sleep or irregular sleep, things like that? You talked about sleep apnea as being something that you think people don't pay enough attention to. Let's talk about that for a moment.
Sure. I mean, healthy living is always important. Whether that's getting good sleep, good exercise, eating well, gosh, stress avoidance and stuff like that. But that's really difficult. There's no
Okay.
patient for that. But yeah, that's always pretty difficult. But yeah, all these things they're highly recommended. Of course, it's easier said than done, right?
Once you've had a procedure like an ablation,
Mhm.
is that I don't know how to say, is that curing the problem and I can go on? I can work out like I did. I can eat. I need to get my sleep. I need to really, now that I've had that ablation, if I have good lifestyle choices, I can really extend my life.
Sure. So it depends on what we're treating. Okay.
Okay.
So certain things like supraventricular tachycardia or supraventricular arrhythmias, things like some of these things. Whenever we do an ablation, it could be curative. Atrial flutter is a circuit in the right upper chamber of the heart that we do an ablation for. 95% of the time after we do the ablation, it goes away. It's considered curative. We
Okay.
even stop people on their blood thinners after that, about a month afterwards.
Okay.
But then there's other things like atrial fibrillation or ventricular tachycardia, those bad bottom chamber heart arrhythmias that where people can pass out and not wake up. Those ablations are not really considered curative. I
Okay.
think we're doing pretty well. And there's like I'm saying, this pulse field ablation
Sure.
thing is quite promising. Uh, they work pretty well, but it's not exactly curative. Uh, that being said, people should, and that's kind of my mission. My job is to keep people doing exactly what they want to do, keep them out
Active
there. Yeah,
lifestyle.
absolutely. No, I mean, it's great to be part of a community where we have a lot of people who are very active, playing pickleball, playing golf, getting out there. And that's kind of the idea from a heart rhythm standpoint is to, if they're having arrhythmias or issues, to keep them going and keep them doing what they love.
mm,
I tell you what, you're very articulate. We really appreciate your
yes.
time, taking time out of your crazy day to do this with us too. We're very
Well,
grateful.
I thought about that when he sleep. He's got two small kids.
Exactly.
How's your sleep?
Yeah.
It's going great.
I love it. Not great. Not great. Thank you so much for
course.
joining us. We want to thank all of you for joining us here today
On Liwanag Health.
Yes. Thank you.